Welcome everyone to the first AOCPMR Medical Student Council Education Committee event of the new 2027 year. I'm excited to introduce our speaker this evening, Dr. Casey Fenger. Dr. Fenger is currently an assistant professor in the Department of PM&R at the University of Utah. He also completed his undergraduate education in exercise physiology, medical school, residency, and fellowship training, all at the University of Utah. He is a recipient of the Mark P. Scott, MD Outstanding Resident of the Year Award and co-recipient of the American Spinal Injury Association's Fellowship Award at the association's annual scientific meeting. Please join me in welcoming Dr. Fenger, and I'll turn the time over to him.
Awesome. Thanks, Jason. Yeah, I'm a Utah lifer, have done all my training here, and I absolutely love it here. So if any of you have the chance to come check it out, please do. So today I'm going to go over spinal cord injury and mechanical ventilation, weaning, and management. My goal is to give you all a 1,000-foot view, what the process looks like overall. So we'll start with some spinal cord injury, respiratory physiology, and pathophysiology. This makes the weaning process and the settings much easier to understand. And then we'll go over settings, management, and the weaning process. So, starting with physiology and pathophysiology. So, there's many muscles involved in breathing, respiration. The diaphragm comes from C3 to C5. Our intercostal muscles are T1 to T11. Abdominal muscles are T6 to T12. We have a couple muscles innervated by cranial nerves, both our sternocleidomastoid and our trapezius. Our scalene C3 to C8, pec major and minor C5 to T1, and the serratus anterior C5 to C7. One of the things to note here is it's not just the cervical spine that's involved with the respiratory muscles. We get a lot of innervation from those thoracic levels as well. So a lot of this becomes relevant even in our patients with those thoracic level injuries. So when we're talking about inspiration, we have quite a few muscles involved in that process. The diaphragm's the main one. That's going to pull about 70% of our overall tidal volume. Then we have our external intercostals, sternocleidomastoid, trap, pecs, scalenes, and serratus anterior. So again, the diaphragm's the big one pulling that tidal volume. Then the rest of these muscles are our accessory muscles of breathing to help with inspiration. Our expiratory muscles, we have abdominal muscles and our intercostals. Now, the abdominal muscles become crucial when it comes to generating a cough, and they make up about 80 to 90% of our cough force. And if you recall from the last slide, that's really comes from our lower thoracic innervated spine levels. So I know you all have probably seen this chart or this graph at some point in your training and or education talking about the respiratory cycle. We have our tidal volume illustrated TV, which is just the volume of our normal breathing that we're all doing right now. Our inspiratory reserve volume is when we take a deep breath as deep as we can. And our expiratory reserve volume is when we expel as much air as we possibly can. And then we all have a certain amount of residual volume, which is dead space, areas of the lung and the airway, which don't participate in gas exchange. So all of these together make up our total lung capacity. In acute spinal cord injury, we see a little bit of this kind of restrictive lung pattern. So our vital capacity, which is the summation of our inspiratory reserve volume, tidal volume, expiratory reserve volume, that decreases. And since that decreases, our residual volume or the lung volume available for gas exchange increases, and then in turn, our total lung capacity remains unchanged. So all in all, we have less areas of the lungs and the airway participating in gas exchange. A big reason this happens is paradoxical breathing. So in an acute injury, we lose tone and innervation to our intercostal muscles. And our intercostal muscles really keep our chest wall intact, provide it structure. So what happens when we lose that tone is your diaphragm contracts to pull in a deep breath, and your chest wall can't hold the chest out, and so your chest collapses in. And when your chest collapses in, it decreases the volume of your chest cavity, thus decreasing the volume of your lungs available for gas exchange. And then you see the abdomen kind of bow out a bit, and that's because of that diaphragm pulling down. And again, you don't have that structure in your abdomen or your chest wall. Interestingly, this starts to improve about 4 weeks post-injury. And this is because this is when we see tone develop after a spinal cord injury. We're outside of the spinal shock phase. We get this tone that develops, and this is a big reason why we start to see improvement in respiratory function when patients come to rehab. So another part of this process is the cough. We talked about the abdominal muscles and how important they are for generating a strong cough. And cough is really key for clearing secretions, mucus, all that good stuff. And if we're not able to clear it, then we can get plugging, which leads to pneumonia. And a lot of not good things happen when we don't clear secretions. And so this device here is actually a meter that you can use to measure peak cough flow. It's something that respiratory therapy does quite a bit. If you're on rotation or you're with pulmonology or in inpatient rehab, I recommend talking to some respiratory therapists and watch them do some of these tests on patients, do them on yourself so you can see what they're like. But anyways, a normal peak cough flow is greater than 360 liters per minute. Anything less than 270 is associated with increased secretion retention. And again, putting you at risk for that mucus plugging and pneumonia. So now talking about ventilator and trach, just kind of basics. So those of you who have done MICU rotations, maybe some OR rotations or anesthesia rotations, maybe are somewhat familiar with some ventilator settings. These are the base ones, the main ones that we use in inpatient rehab. So the PEEP is the positive end expiratory pressure. This is also the pressure that's routinely set on like a home CPAP machine. The inspiratory pressure, sometimes this is denoted IP or pressure support. This is the pressure that's delivered when someone is actively taking a breath or you're trying to give them a breath. We have respiratory rate. FiO2 is the fraction of inspired oxygen, where you set the percentage of inspired O2. And then VT is tidal volume. So ventilator modes, there's control modes and assist modes. So control modes, we'll go over pressure control and volume control. What makes them a quote unquote control mode is the ventilator is initiating all the breathing for the patient. The patient doesn't trigger breaths. So if the patient is completely apneic, the ventilator is still going to breathe for them. So pressure control, you control the PEEP, the inspiratory pressure, the FiO2, and the respiratory rate. What you don't control is the tidal volume, and this is variable and changes based off of the pressures that you set. Volume control is kind of the opposite. You control the tidal volume, the FiO2, and the respiratory rate, and the pressure is variable based off of the changes you make in the tidal volume. Now, those of you who have done ICU rotations, one of the big things is they use volume control almost exclusively, and that's because they want to control the volumes to be around 6 cc's per kg in order to avoid barotrauma. There are certain situations they will use pressure control, but a lot of vents are set to volume control. Pressure support, what makes the support different from the control is on support modes, the patient has to trigger the breath. And so if a patient's apneic, not breathing, not trying to trigger a breath, the vent's not going to do anything. And what you control is the FiO2, the PEEP, and the inspiratory pressure. This is pretty similar to a BiPAP machine that someone would wear at night. This next setting, SIMV, which is short for synchronized intermittent mechanical ventilation, is a setting that we use quite a bit on rehab. And it's a combination of volume control and pressure support. So how it works is you set a volume control setting. So you're setting a volume with the respiratory rate that you want to ensure that the patient gets. And so regardless if the patient's triggering a breath or not, they're going to get that many breaths per minute of a set tidal volume. Then you also set to pressure support. And so if a patient tries to breathe outside of the set respiratory rate, or is triggering their own breaths, then the ventilator is going to give them some pressure to help support that breath. So now the basics of trachs are very simple. Maybe some of you have seen them before, but we have basically a tube. It has sometimes there's a cuff at one end here, this balloon that inflates. We have a flange that goes on the neck. Then we have the exterior portion of the trach, and then we have this tube that comes down and loops around to where we fill up the balloon. So the way it sits inside the airway is it curves down nicely right into the trachea. You can see the cuff here. What the cuff is used for is when the cuff is inflated, you create a closed circuit with the ventilator. All the pressure that is being administered by the ventilator is on a closed circuit. When you deflate the cuff, air and pressure can escape up out through the mouth. Therefore, it's an open system and less controlled. And one of the things we use with trachs are speaking valves and caps. So the top two are the example of a speaking valve. The green speaking valve you put in line with the ventilator circuit. The purple speaking valve is one you place when someone's off of a ventilator. And then we have a cap, which just closes off the trach. The way the speaking valve works is they're one-way valves. So air can come in, but not out. So when a patient takes a breath or they're given a breath by the ventilator, air goes down into the lungs. When they exhale, it actually comes up all out through the mouth. And that allows us to speak because then air is passing past the vocal cords. One of the main things to watch out for when a patient has a speaking valve on is making sure the cuff is deflated. And that is because if air is coming in and you have the cuff inflated, air can't get out, which can be a problem, and you're essentially occluding someone's airway. So now we're going to get into the general weaning steps and weaning process. And again, this is a 1,000-foot view, and there's 3 key steps to this process, and all 3 of these things are done together. So first is secretion management, then we have progressive ventilator-free breathing, and then we'll talk about trach downsizing and decannulation. So secretion management. This is crucial. If you're not managing secretions, you're not going to be able to wean someone off the ventilator, and they're going to have a lot of complications. So just a couple methods we're going to talk about today. One is suction. Suction works great for clearing the upper airway, but it does not clear the lower airway. So if we look at lung here, the trachea, and our main bronchi, you really can't suction anything below the carina here because you're not going to be able to get into the main bronchus. You're certainly not going to be able to get into the far depths of the lower lungs, right? The other interesting thing about this is when someone is getting respiratory or secretion management solely with suction, it's very common to get mucus plugging and pneumonia in the left lung. And that's because of the orientation of the bronchus. So it's kind of the opposite of the aspiration pneumonia being most common in the right lung, kids aspirating things being common in the right lung. That's because this bronchus is a little more vertical, so things like to go right down into the right lung. Therefore, it's also easier to get things out of the right lung. Whereas the left lung, it's a little more difficult to get secretions out because of the horizontal orientation of that main bronchus. So what we use to clear out the lower airway is mechanical insufflation exsufflation. The brand name for this is Cough Assist. Maybe some of you have heard of it, and it does a really good job of clearing the lower airway. This is something we routinely use 4 times a day in someone with a new injury. Our chronic spinal cord injury patients do this twice a day. It's like brushing your teeth. And this is critical for those patients with those peak coughs of less than 270 liters per minute. The way it works is it gives a deep breath, expands the lungs, and then quickly creates a vacuum to pull all the air out, which is like simulating a cough. For every session, you do a handful of cycles to get those secretions out. And this can be done through a trach and or a face mask. So progressive ventilator-free breathing, which is a way of saying we want to progressively remove ventilatory support to train our respiratory muscles. So our respiratory muscles are similar to any other muscles in the body, right? If you don't use them, you lose them and they get weak. A lot of our patients have been on a ventilator for anywhere 2 to 4 to 6 weeks sometimes before coming to inpatient rehab, and the respiratory muscles are atrophied. We've all had that experience where we have a New Year's resolution or decide we're going to run a marathon or whatever, and you get up off the couch and go exercise hard. We feel great. It's awesome. We're exercising and we completely overdo it. Then for 3 or 4 days, we're super sore, have a hard time walking, and we can't do anything. Our respiratory muscles are the same way. So the goal is to challenge these muscles, but not wear them out. So we get into ventilator settings and how we do this. We'll start with SIMV. That's that mode that's a combination of volume control and pressure support. The first thing we do is we start to decrease the respiratory rate that we set on the volume control portion of SIMV. What that does is it requires the patients to trigger more breaths on their own and try to pull more breaths on their own. Then we can reduce the pressure support that's given for those breaths that they individually trigger. So there's a lot of tinkering that can be done on this SIMV mode, reducing the respiratory rates and reducing the pressure support. So when someone is ready to graduate from SIMV, they no longer have a set rate for the volume control. Then we transition them to pure pressure support. This requires patients to pull all the breath on their own, and we can give them pressure to help them. And then over time, we gradually reduce that pressure. So some troubleshooting and roadblocks that we run into with this progressive ventilator-free breathing and trying to get someone off of the ventilator. One, again, is that secretion clearance. This is such a big part of this. And if you're not able to clear these secretions, again, you can't get someone off the ventilator. They're going to have continued pneumonia as well as mucus plugging. Anxiety is a big part of this. A lot of these patients have been on ventilator support for weeks. And so taking that support away can be really discerning to them and anxiety provoking. A lot of them feel like they can't breathe, they can't catch their breath, almost like they're underwater. So we'll try to actually wean during other activities. So when someone's doing OT or speech, PT, maybe a rehab psych session, doing something to distract them from the fact that we're decreasing their ventilatory support. Patients, especially older patients, a lot of times have additional pulmonary diseases, things like asthma, COPD, pulmonary fibrosis, people who are smokers. All these things can confound this process. If available, it's good to talk to pulmonology and maybe ask them to help troubleshoot with you, especially managing these chronic pulmonary disease processes. We do a lot of arterial blood gases. This really helps us dial in the settings, mainly monitoring for CO2 retention. And this is because hypercapnia is not your friend, right? It's a bad thing. It can lead to somnolence and respiratory failure. So it's something we really want to avoid. The other thing with hypercapnia is it can be sneaky. So it can kind of gradually building over time and you don't know it until you run into a problem. And so whenever we make a big change with the ventilator, we're always checking blood gases to make sure the patient's ventilating okay, breathing off the CO2. And again, pneumonia, right? A big part of this. A lot of these patients do end up getting pneumonia, whether it be before they come to rehab or during rehab. It's just an unfortunate part of the process. With these patients, common signs include increased secretions, increased oxygen requirement, and of course, fever and other signs of infection. Things that we do here, always get a sputum culture and a MRSA swab because this helps guide antibiotic treatment. A lot of these patients, since it is ventilator-associated pneumonia, do get resistant bugs. Okay, let's say you do all of this and you're still not able to get someone off a ventilator. We do have phrenic nerve pacers available. These are really cool. I have a few patients with them. And what they do is directly stimulate the phrenic nerve. A surgeon goes in, puts a electrode lead on the phrenic nerve itself, and then you have an antenna that's outside of the body that goes over the leads that then stimulates the phrenic nerves to take a breath. Where this becomes difficult is it doesn't work if the diaphragm is denervated. So if someone has an injury around C4, C5, C6, and they have an injury to those nerve roots that, give rise to the phrenic nerve, the pacing's not going to work. So this works best in those patients with injury levels of to C3. Occasionally, someone with a C4 is able to get this done, but again, if there's damage to the peripheral phrenic nerve itself, these devices won't work. So once we go through that whole process, then we can talk about getting someone off of the ventilator. And we transition to high flow once they're off the ventilator. This can be done a couple different ways through either a T-piece or a trach mask. The T-piece is this picture on the left. It looks like a T. You can see the speaking valve in line with the oxygen hose. The nice thing about T-piece is you can also hook up suction at the same time. And so that's readily available. It does provide kind of amount of positive pressure, but very small. The trach mask down here on the right is, the name implies, it's just a mask that goes over the trach. It delivers high flow oxygen. The difference is this can't be attached to suction. And so in order to, for a patient on a trach mask, you have to remove the trach mask, take the speaking valve off in order to access the trach for suction. So now getting into, trach itself and eventual decannulation. So first off, the cuff. We already talked a little bit about the cuff. Inflated, it creates that closed circuit with the ventilator in order to provide like optimal support. When we deflate that cuff, air can escape past the mouth, right? To help us talk, things like that. So first part of trach weaning is deflating that cuff, creating an open circuit. We're not able to give as much support to the patient, and it kind of trach wasn't there. Now, changing the size of the trach and downsizing it is a big part of that process. And these trach sizes are based off of the inner diameter of the cannula in millimeters. So common sizes you see we like 80, 60, 40, right? The smaller the number, the smaller the size. So when you're trying to do speaking valve trials or trying to deflate the cuff to see how much a patient can breathe outside of using the trach. If you have a big trach in, like a 10 or an 8.0, it's hard for the patient to do that because the trach itself is so big that it's covering a majority of that airway. So when we start this process, we like to downsize the patient to, and again, that smaller trach allows more air to pass. But for having a bigger trach in is you can provide more vent support, right? Bigger tube, more air can pass through, you can provide more support. And so as long as someone's doing okay with minimal vent settings, it's okay to downsize them. We like to wait 7 to 10 days after the tracheostomy is placed to allow for that full stoma to develop. So when you take the trach out and put a new one in, it has a nice new clean track to follow. So we already talked about some of this, the cuff down, trialing the speaking valve, transition to a cap. When we talk about decannulation, we want to decannulate from a 6.0 and smaller. And that's because if you have a big 8.0 trach in there and you decannulate somebody, they're going to have a really big stoma and it's going to take time to heal. You're going to run into issues with a lot of air escaping through that stoma, even when you're trying to cover it. So it's good to, take the time and gradually downsize the trach. And again, you can downsize as you're also working on that progressive ventilator-free breathing. Now, these stomas, they heal very quickly. So typically the tracheal cartilage will close within 3 to 5 days, close completely. And then the skin closes in 1 to 2 weeks. So that's kind of, view of this process without any real detailed specifics, but those are all the things that we think about and the process we go through when we're weaning someone off a ventilator. And the reasons why I really enjoy doing this as an inpatient rehab doc is it really challenges you, right? Every patient is very different. Every patient has differing levels of anxiety, pre-existing pulmonary disease, respiratory muscle weakness. There's a lot of factors that go into this weaning process, and every process is different, or every patient is different. And so we have a generalized weaning algorithm that we follow, but again, it's not necessarily going to work for every patient, which makes it challenging and it really adds a lot of complexity to the inpatient rehab process. What you're doing with the ventilator and the weaning process directly impacts what someone can do in therapy, right? If you push their respiratory muscles too hard, then they're not going to be able to participate in much therapy for a couple days. And so it really is tied to the whole process. And the team approach to vent weaning is huge. So, those of you interested in rehab, maybe you've done a rehab rotation, there's a very, very team approach, right? And the vent weaning just adds to that. So now we're including, having rehab psych handle or help with the anxiety piece. You're working really closely with respiratory therapy. You might be consulting pulmonology because the patient has other pulmonary diseases. Therapy might be seeing something during their sessions that cues us into maybe they are retaining some CO2. Speech is working on the trach wean and speaking valve. And so it is a full approach. And these are all the reasons why I really enjoy being a part of this process in inpatient rehab. So with that, thank you guys for signing on and let me know if you have any questions.
Yeah, if you guys just want to drop any questions into the chat, I'll go ahead and read them and then we'll get answers. And then we do have some pre-submitted ones too that we can go through if there aren't some in the chat. But this one from Brock Slade says, Dr. Fenger, really appreciate the overview on ventilator management. Naturally, it is patient dependent, but how long is the transition from SIMV to PR to ventilator-free breathing on average? And what does that timeline look like?
Yeah, great question. We actually just did a study on that here at our institution, and this can be anywhere from weeks to months. It is very patient dependent, but typically, let's say someone with like a CT cord injury, we were on the SIMV mode and trying to transition to pressure support over the course of a couple weeks, sometimes 3 weeks, and that's with gradually decreasing the rate, gradually transitioning over to pressure support. Once they're on that primarily pressure support setting, it goes a little bit quicker. So when we can get them to that point, we can transition to off vent pretty quick, probably in, about a week. One of the issues we do run into is rates of sleep apnea are very high in this population. And so some of these patients getting that pressure support off at night is very difficult. And sometimes that can be the barrier to getting somebody completely off vent. So yeah, it's usually on average a 4 to 6 week process for those, mid, and that's assuming someone's like, no longstanding pulmonary disease. But we do have some patients that I've seen in clinic a couple months after inpatient rehab, and that's when they've been able to get off the ventilator.
One of the pre-submitted questions was, in patients with high cervical spinal cord injuries, how do you assess the diaphragmatic function early on? And does it help you predict long-term ventilator dependence, particularly in that early acute phase?
Yeah, that is a fantastic question. This is something that the field is actively currently trying to figure out. So part of this process is their injury level. Well, we base that off of the INSCI, the AIS exam, and that's a physical exam, and it can't necessarily tell you the nuances of the diaphragm function. One thing that, or a couple things that people have published on is doing diaphragm EMGs as well as diaphragm ultrasound. These are things that show quite a bit of promise. One of the problems with the diaphragm EMG is that it's very technically difficult to do. And I'm not very excited about sticking an EMG needle into someone's diaphragm for a multitude of reasons, right? And so it's one practically more challenging. The the ultrasound is interesting, and I think that's the direction things are probably going to go towards. Again, one of the hard there is a lot of, community in smaller areas aren't going to necessarily have the technical training to do that. I don't know how to do that. It's something that I hope later on in my career I'll learn how to do. But I think that's a way that we're going to be able to better assess diaphragm function. One you know, way you can check on inpatient rehab is just how much tidal volume are they able to pull with minimal pressure support, right? You can easily just turn the ventilator off or turn the pressure support down to zero and ask the patient to take a deep breath and see how much they're able to pull. Again, that's not perfect early on, but as time goes on, that can cue you in.
That kind of leads into this next question that was submitted. Are there specific clinical or physiologic predictors, such as vital capacity or tidal volume, that you rely on to determine readiness for ventilator liberation?
Yeah, that's also a great question. So there's we talked about last question, assessing if the ventilator can pull adequate tidal volume. So that's one thing we look at. We typically like to see people pulling tidal volumes of 8 to 10 cc's per kg, kind of 500 range, bigger people, maybe somewhere in the 600 cc range. So that's something we keep a close eye on, and they need to be able to pull that consistently, and with minimal pressure support. So if we take their pressure support down and they're only pulling volumes of 200 cc's, that's not enough, right? They need to be in that 400-500 zone consistently. The CO2 part of this is piece. So if somebody is pulling adequate tidal volumes, but is routinely hypercapnic, so say their CO2 is routinely above 40, we're up at 45, even if they're compensated, they're not to come off the ventilator. And that is because even though they're pulling the tidal volume, they're not breathing off that CO2 and they're not effectively ventilating. And that's something that over the course of, three can get you into trouble. Those are the two main physiologic markers we look at are the tidal volumes that they're pulling and what their blood gas looks like.
And then the last one of the pre-submitted questions, you kind of mentioned this a little bit, but maybe diving a little deeper into it. In your experience, what are the most common barriers to successful ventilator weaning, and how do you involve the entire interdisciplinary team to best address those barriers?
Yeah, the routine barriers I run into are the cough assist and the anxiety piece. And that's like if let's put aside, someone has complete C1 or a C2 injury and they're not neurologically intact enough to wean. But if someone is neurologically intact enough to wean, those are definitely the biggest barriers. Um, so from the secretion clearance standpoint, a lot of patients are adverse to cough assist. If you have the opportunity to have a respiratory therapist do cough assist on you, you should. It's uncomfortable. It doesn't feel great, and patients don't like it. And, they sit and they think, I don't need cough assist. I'm fine. It's up anyways. And then 3, 4 days later, they have a plug and they have a whole section of lung that's shut down and they have to go to the ICU for a bronch. That happens a lot. And that kind of spins into the next piece, which is the anxiety piece, right? People have cough assist, anxiety over being taken off ventilatory support. And so, how we include the whole team in that is we make sure every day the therapists, the nurses, the aides, RT, the education team, the psychology team, everybody knows what we're doing with the ventilators. So when they're in a session with the patient, they can give us feedback on, how they process is going. Because as a medical provider, you only see the patients for a few minutes in the morning, unless something's going wrong later in the day. And it's really the rest of the team that has most of the hands-on patient time. So they give us great information. And then to combat like the cough assist and anxiety barrier, rehab psych also have an education team here. Those people are huge. The education team goes through why cough assist is important, shows pictures, talks through the process, really helps educate the patients. And then the rehab psych team then gets to the root of the patient's anxiety. Some people, by avoiding the topic and not talking about it, therefore we distract them by weaning during therapy sessions. Some people do better by managing their anxiety head on. No, I want to know everything you're doing because it helps me understand it better. And rehab psych then informs us, which way better to address this patient's anxiety to get them off and to help them wean.
Next one from the chat says, just a general question. In inpatient rehab, would you say that ventilation management is a major part of your day to day?
For my practice, it is. These are patients I prioritize and I really enjoy taking care of. It's again the team approach, working with respiratory and pulmonology, and it's a complex process. And so I kind of go out of the way to make it a priority in my practice. And, the spinal patients on the ventilator are a piece of that, but not all of it. I have a few brain injury patients on ventilators, as well as transplant patients on ventilators. So there's a whole array of patients we get in who are on these ventilators, and it's definitely a big part of my practice. I would say I usually have, one to two of my patients are on ventilators, out of 12 on an inpatient service, but they take a lot of time, right? So that's actually a big part of your caseload, just those couple patients.
Perfect. Any other questions that anybody has? In the ICU, I was taught about ventilator vacations. While the patient is in inpatient rehab, are probably not as sedated with the goal of weaning. Do you all incorporate these vacations or anything similar in inpatient rehab? If so, how often?
Yeah, good question. So that is our version of a vacation is decreasing the support. And so you're right, the patient's not sedated. They need to be doing rehab. And so that's when we kind of gradually like we'll in and we'll say, hey, let's turn the pressure support down for an hour and let's see what happens. Or let's just turn the respiratory rate off of the SIMV mode and see what happens. So those are things that we do every single day. We just don't need to have the sedation vacation on top of it, because we have good airway access through the trach, so they don't need to be sedated. But yeah, we're constantly giving breaks from the ventilator to see how they can do.
Thank you so much, Dr. Fanger. This has been incredible. I think everyone's probably overloaded with a little bit of information, and
Yeah.
that's even that 1,000 foot view. So
Yeah.
I appreciate you the time and wish everybody a good night.
Yeah, thank you guys much, and thanks for signing on. Jason has my contact info, so if you have any additional questions or this is a particular area of interest for you, please feel free to reach out.